So, Assalamu alaikum. Good afternoon. Firstly, I would like to thank Dr. Khabir sir and the team of DAIL for having me here to speak on diabetic retinopathy. I'll be discussing diabetic retinopathy in following subheadings and discussing advancements in it as and when applied. So, as an ophthalmologist and retina specialist, I take privilege in saying that retinal vessels are unique in a way as they are the only blood vessels of the body that can be viewed directly. So, many of the systemic disorders can be diagnosed by seeing those retinal vessels. So, diabetic retinopathy is a progressive dysfunction of the retinal vasculature caused by chronic hyperglycemia resulting in structural damage to the neural retina. So, in addition to diabetic retinopathy, I would also like to say that there are other complications which can affect the ocular structures. That includes dry eye, which occurs due to corneal neuropathy and loss of corneal sensations, which also leads to neurokeratopathy also due to loss of corneal sensations. There is also a change in refractive error, sometimes due to hyperglycemia. We have come across cases whose blood glucose levels were not under control, and they got the prescription and got the glasses done, and they came back after a few weeks with blurring of vision. That is because of the change in the size of the lens that will cause in the change in the refractive error, and they might lose 3,000, 5,000, whatever they have paid for those glasses. And other complications is glaucoma is also commonly seen in patients with diabetes, primarily open-angle glaucoma. Neovascular glaucoma is a late complication of diabetes that leads to sight-threatening complication of vision loss. Cataract, snowflake cataract is common in diabetes. In addition to snowflake cataract, we have seen people having early onset of cataract and rapid progression of cataract rapid progression senile immature cataract. As diabetic can cause damage to the nerves, it can also cause peripheral cranial nerve palsies. In addition, gradually damage to the peripheral nerve, it can also cause cranial nerve palsies, which supply the orbit that includes third, fourth, and sixth cranial nerves. It can cause diabetic papillopathy and non-arthritic anti-ischemic optic neuropathy, which is infarction of the optic nerve head. So, diabetic retinopathy is the most common microvascular complication of diabetes mellitus. It is the most common and severe ocular complication of diabetes, and it is the leading cause of visual loss in adults of the working age group. So that is the significance that it is the leading cause of visual loss in adults of the working age group, which will have a severe impact on the nation's economy. It is directly proportional to the patient's age, duration of diabetes, poor glycemic control, and fluctuating blood pressure levels. So according to the International Diabetes Federation, the global burden of diabetes mellitus is 537 million in 2021, which is estimated to increase to 643 million by 2030. That is, 1 in 10 people worldwide is living with diabetes. So India is set to become the diabetes capital of the world, with an estimated 74 to 77 million people living with type 2 diabetes, which is second in world in prevalence, and 25 million are pre-diabetics. The disturbing trend is that there is a shift in the age of onset of diabetes to younger age group, which is directly impacting the nation's health and economy. So, coming to the diabetic retinopathy, 1 in 3 patients with diabetes suffers with some form of diabetes, either mild, moderate, whatever it may be, they form. But good thing is that very few, that is less than 10% of the patient will be affected with visual threatening diabetic retinopathy complications, which include diabetic macular edema or proliferative diabetic retinopathy. So, when comparing type 1 and type 2 diabetics, the prevalence of diabetic retinopathy is more commonly seen in type 1 diabetes, which is 77%, and approximately 25% of patients with type 2 diabetes are suffering with diabetic retinopathy. Proliferative diabetic retinopathy is seen in very high average blood glucose levels, which is more commonly seen in type 1 diabetics, and diabetic macular edema or maculopathy is more common in type 2 diabetics. Diabetic retinopathy is almost double in diabetics who develop diabetes less than 40 years of age. So, duration of diabetes is the best predictor of diabetic retinopathy. It rarely develops within 5 years of onset of diabetes, but irony is that we come across 5% of patients with type 2 diabetes have retinopathy who were undiagnosed previously as diabetics. But The patients with type 1 diabetes have 25% risk of suffering with diabetic retinopathy after 5 years of onset, and it increases to 75% after 10 years of onset of diabetes. Whereas in type 2 diabetes have a 35% risk of developing diabetic retinopathy after 5 years of onset of diabetic, which increases further to 55% in after 10 years of onset. After 20 years of diabetes, nearly 99% of type 1 diabetics and 60% of type 2 diabetics have some form of diabetic retinopathy. So risk factors of diabetic retinopathy are non-modifiable and modifiable. Non-modifiable risk factors are age of onset and pregnancy, which is not under control, but modifiable risk factors, which is poor glycemic control, which is also evident in clinical trials, which are landmark clinical trials like United Kingdom prospective diabetic study and diabetic control and clinical complications trial, which has clearly shown that importance of strict blood sugar control, which slows down rapidly the progression of diabetic retinopathy and severe vision loss. Hypertension is also the important risk factor for developing diabetic retinopathy, and which is also shown in United Kingdom prospective diabetic study that reducing the blood pressure, systolic blood pressure to 10 millimeter and diastolic pressure to 5 millimeter have severely reduced the progression of diabetic retinopathy. Obesity and dyslipidemia are the other risk factors. Patients with mild nephropathy have 2 times risk of developing diabetic retinopathy, and patients with advanced nephropathy have 6 times risk of developing diabetic retinopathy. Smoking, which is also affecting the cardio, which is the most important factor, one of the important factors in cardiovascular events, is also one of the risk factors for diabetic retinopathy. Anemia, which is again hypoperfusion and reduced oxygenation of the tissue, has having a 2 times risk. Patient with diabetes have 2 times risk of developing diabetic retinopathy. So coming to the pathogenesis, diabetic retinopathy is nothing but the microangiopathy, which has features of both microvascular leakage and microvascular occlusion. Larger vessels might also be involved in pathogenesis. The underlying pathology is that hyperglycemia leads to activation of several pathways, which includes polyol pathway, leads to formation of sorbitol, which is causing cellular damage. In addition to this, hyperglycemia also causes oxidative stress damage and releasing of reactive oxygen species, protein kinase C activation, and renin-angiotensin system activation, which causes vascular endothelial dysfunction, leading to increased vascular permeability, leading to diabetic macular edema. It also causes retinal ischemia and causes release of VEGF and other inflammatory mediators, which is again causing retinal neovascularization. The importance of VEGF is shown here, that VEGF is the target molecule which is being used as a pharmacotherapy for management of diabetic retinopathy. So, microvascular leakage, as I've shown, is due to leakage from the micronerisms and also disruption or breakdown of the blood retinal barrier causing retinal edema and leakage of cholesterol causing hard exudates. So, microvascular occlusion occurs as a result of basement membrane thickening, endothelial cell damage of the capillaries, deformed RBCs and platelets thickness, which all these leads to hypoxic retina, leading to production of vascular endothelial growth factors, which stimulates the growth of shunt and new vessels. So, the gold standard for detection of diabetic retinopathy is nothing but the dilated fundus evaluation, which is done with slit lamp 90D examination or indirect ophthalmoscopy 20D. Direct ophthalmoscope can also be used to diagnose, but it lacks stereopsis. So, the progression of diabetic retinopathy is from the mild or undiagnosed stage to a proliferative stage. This needs a careful fundus evaluation to look for the signs of microaneurysms, intraretinal hemorrhages, hard exudates, cotton wool spots, venous bleeding, eryma, new vessels, etc. So, microaneurysms are nothing but the earliest clinically detectable lesions of diabetic retinopathy. They are nothing but focal saccular outpoachings of the weakened capillary wall, where pericytes are lost due to microvascular damage. Their diameter is less than 125 microns. They are red and sharp regular margin, which needs to be differentiated from hemorrhages, which have irregular margins and their size is more than 125 microns. These hemorrhages are nothing but the rupture of the weakened capillary wall and located in the deeper retinal layers. There are also superficial hemorrhages which are flame shaped, which are located around the disc, and it takes the shape of a splinter because they are located in the retinal fiber layer. Hard exudates are usually located on the posterior pole. They are yellowish deposits of the lipids, lipoprotein, lipid-filled macrophages, usually located in the outer plexus nuclear layer, and they are arranged in clumps, or they can be arranged around a leaky microaneurysm in the form of a ring. Cotton wool spots are nothing but infarcts of the precapillary arterioles, and they appear as white fluffy lesions in the nerve fiber layer. Irmas are shunt vessels which are present between arterioles and venules, which are usually located around the capillary non-perfusion areas, which acts as a bypass to the capillaries. So they should be differentiated from the new vessels. Usually in the fluorescein angiography, the irmas won't leak, whereas new vessels will leak in fluorescein angiography. The venous changes in diabetic retinopathy includes dilatation, looping of the vessels, beading of the vessels, and sausage-like segmentation. And arterial changes can be seen in the late stages of diabetic retinopathy in the form of peripheral narrowing, silver wiring, and obliteration. So, neovascularization, coming to the neovascularization, which is seen in the proliferative stage of diabetic retinopathy, it is again classified into neovascularization in the disc, which is new vessels at the disc or within 1 disc diameter of the optic nerve head, and neovascularization elsewhere is nothing but the new vessels which is away from the 1 disc diameter of the central, away from the 1 disc diameter of the optic disc. Neovascularization of the iris is a late complication, and it has got a poor prognosis, which can also cause neovascular glaucoma. So, in the year 1968, Airlie House Symposium was attended by ophthalmologists to grade and to have a standard to grade and treat diabetic retinopathy. They employed a standard photograph. These photographs include 7 fields of fundus image with 30 degrees photo. This fundus imaging was used in ETD, early treatment diabetic retinopathy study, to classify diabetic retinopathy into non-proliferative and proliferative stage. So, according to ETDRS, non-proliferative diabetic retinopathy is divided into no retinopathy, where there is no retinal lesions, very mild NPDR which have only microaneurysms, mild NPDR which have fewer aneurysms or retinal hemorrhages and cotton spots, moderate NPDR which have retinal hemorrhages in 1 to 3 quadrants of the fundus, and mild irma and venous bleeding. That I will be showing in a few later slides. The fundus image which were used as standard to grade this retinopathy. Severe NPDR is fulfilling one rule of the 4-to-1 rule. The 4-to-1 includes severe hemorrhages in all 4 quadrants, which is seen in standard photograph 2A. Venous bleeding in 2 or more quadrants is seen in photograph 6A. Moderate irma in 1 or more quadrants seen in photograph 8A. So these are the standard photographs which I discussed in modified Airlie House classification, which were used to document diabetic retinopathy. So eyes with severe NPDR have this degree of severity. I'm sorry, I can't use this pointer here. So this amount of hemorrhages and microaneurysm in all the 4 quadrants to grade it as a severe NPDR. Whereas you can see bleeding in the major vessels. I think red-free image is better to document the bleeding. So, the patient is graded as a severe NPDR when this amount of bleeding is seen in 2 or more of the quadrants. And irmas, you can see that this amount of irma is present in 1 quadrant, the patient is graded as severe NPDR. This is standard photo of 8A. So, in addition to this, non-proliferative, we have got proliferative diabetic retinopathy, which has again graded into mild proliferative diabetic retinopathy, moderate, high risk, and advanced PDR. So, mild PDR is nothing but neovascularization elsewhere less than half disc area. Moderate PDR is neovascularization elsewhere half disc area, or neovascularization of disc less than 1/3 disc area, which is shown again in standard photograph 10A. So, this amount of neovascularization present, the patient is graded as high risk PDR. And other high risk characteristics are any NVD with vitreous hemorrhage or neovascularization elsewhere with vitreous hemorrhage is considered as a high risk PDR. Advanced diabetic dialysis is the end stage, which is the retinal complication, which includes intraocular hemorrhages, tractional retinal detachment, or rubeosis iridis, and this is advanced diabetic dialysis. You can I'm sorry, I can't point it out. Here that case, there is a traction retinal detachment involving macula in the left side of the image, and there is a massive pre-retinal hemorrhage obscuring the fovea. So there is ETDRS has also classified macular edema as CSME, which is retinal thickening. In the left upper corner, you can see that there is a retinal thickening within 500 microns to the center of the macula, and in the upper right corner, you can see hard exudate outer within 500 microns of the center with adjacent retinal thickening. or a retinal thickening with this one disc area in size, a part of which is within one disc area of the center of the macula. So, coming to the documentation, fundus photography is used in to document and grade the diabetic retinopathy, and also it helps in patient education with counseling. The standard 7-field Moorfield early house classification should be taken, but now because of the advent of newer imaging system that I'll be discussing later, the role of fundus photography is again to counsel the patient and educate them the severity of the retinopathy. Fluorescein angiography, which was previously one of the major diagnostic tool in grading diabetic retinopathy, not frequently used nowadays, but it is used in some cases like to diagnose ischemic maculopathy, to find out the unexplained visual loss in patients, and also to differentiate IRMA from neovascularization, which I have discussed previously, that IRMAs won't leak and neovascularization leaks on fluorescein angiography, and also to reveal occult new vessels which could have been missed in clinical examination. Now, advancements in imaging is nothing but ultra-wide field fundus imaging and ultra-wide field angiography, which takes a posterior fundus image in a single frame. You can see here, if early house standard photos were taken, the peripheral vasculature would not be seen and would not have been documented. And with this image, you can be clear that in fluorescein angiography, if it was done with standard photographs, then the peripheral vascular neovascularization would have been clearly missed, and we could have missed a proliferative diabetic retinopathy case. So, coming to optical coherence tomography, it is one of the very important tool in diagnosing diabetic macular edema, and also in monitoring, prognosticating the edema to plan intravitreal injections. It also helps in differentiating other causes of loss of vision, which is vitreomacular traction, epiretinal membrane in diabetics. So, upper image is a normal fundus image, normal OCT image, and lower two images are nothing but edema, which is shown. And this left side image is nothing but a non-tractional DME, which is treated with intravitreal injection. The right image is a tractional DME, which needs surgery. This is how OCT helps in differentiating these two cases. Ultrasound B scan is a useful tool in hazy media, which is employed usually in cases of cataract or vitreous hemorrhage to assess the status of the retina and to plan the surgery accordingly. So optical Octa, it's advancements in again OCT imaging. It employs motion contrast image to retinal flow. It generates images similar to fluorescein angiography without the need to inject the dye invisibly, especially used in patients with kidney disease and patients prone to anaphylactic reaction of the dyes. So you can see the left image is nothing but the OCT angiography image, which is similar to those seen in fluorescein angiography, but in this there is no dye used and no invasive procedure being used. And this is a Octa image. You can see with a red arrow, in a red arrow there is neovascularization and capillary non-perfusion areas in the periphery. Yellow arrow showing IRMA, and green arrow showing aneurysm. And also Octa also non-invisively diagnose macular ischemia, helps in diagnosis of macular ischemia. The left image is nothing but a normal foveal avascular zone, which is disrupted in macular the macular ischemia. You can see in right images. So that is seen sometimes in unexplained visual loss in diabetics. So the management of diabetic is first and foremost is metabolic control, which is actually evident in landmark clinical trials like diabetic control and complication trial and United Kingdom prospective diabetic study, which has shown the significant reduction in the need of focal laser, and also decrease the progression of diabetes once blood glucose and blood pressure is effectively controlled. And also the role of cholesterol is demonstrated that in EDD arrest, twofold increase in risk of heart attacks were seen with increased levels of serum cholesterol. And in these diabetic control and complication trial, it is shown that there is significant association between occurrence of CSME and levels of LDL cholesterol. Phenylfibrate in one study which used reduced the frequency of laser photocoagulation for treatment for DME by 31% and PDR by 30%. It is important to highlight here that thiazolidine diones, that is rosiglitazone and pioglitazone, which were used in managing diabetic cases, are more likely to develop DME. Now coming to the specific ophthalmic treatment, so sight-threatening diabetic retinopathy includes severe NPDR, PDR and CSME. So the diabetic retinopathy, if untreated, what happens? So, if untreated, it might lead to complete visual loss due to tractional detachment, causes formation of membranes, and also iris neovasculature leading to neovascular glaucoma. And if diabetic macular edema, if left untreated, causes subretinal fibrous and RP pigmentary changes which are irreversible. So, coming to the management of diabetic macular edema or clinically significant macular edema, intravitreal anti-VEGF are the first line of therapy for DME. So, they reverses visual impairment by decreasing the macular edema. In addition to the effect of decreasing macular edema, its concomitant effect of anti-VEGF is improvement in the retinopathy severity, slowing the rate of progression of retinopathy, and thinning of the choroid, and the frequency of injection appears to decrease with time. So there are many anti-VEGF agents because VEGF has an important role which I have discussed in pathogenesis. The target molecule is VEGF. So many VEGF antagonists is being coming up and acts as an armamentarium in the management of DME. So bevacizumab, ranibizumab, aflibercept, newer anti-VEGF like faricimab and brolucizumab have come up in managing DME. Bevacizumab is a monoclonal antibody which binds all VEGF isoforms, and ranibizumab is just a fragment of antibody which forms more effectively when compared to the bevacizumab, and aflibercept is the fusion protein which binds not only with the VEGF-A isoform but also binds with VEGF-P and pregnant direct growth factor. So, the contraindications of VEGF are a major systemic events in the past 3 months. This is again important for the physician that major systemic event in the past 3 months like stroke, cardiac arrest or controlled hypertension is a contraindication to give anti-VEGF injection. And anticoagulant use, patient if he is on anticoagulant, it is a relative contraindication of usage and giving intravenous injections. Patient with fibrovascular proliferation threatening macula is a contraindication of usage of anti-VEGF. Patient with active ocular or periocular inflammation is again a contraindication with usage of injections, any injections, and known hypersensitivity to anti-VEGF agents. So, due to high cost of these biologics, the biosimilars are now coming up to reduce the the cost for patient treatment. They are biologic products that are very similar to reference product with no clinically meaningful difference in terms of safety, purity, or potency. They are cheaper because of the cheaper cost for research and development, and FDA requires much less extensive clinical trials for biosimilar approval. So that's why they are cheaper. The role of corticosteroids in the management of diabetic macular edema is because of its anti-inflammatory and anti-VEGF effect. It was first used in treatment of DME, but these corticosteroids are found to be less potent when compared to anti-VEGF agents in the management of DME. The corticosteroids which can be injected intravitreally are triamcinolone, dexamethasone, and fluocinolone. So Ozurdex implant is a opaque cylindrical biodegradable implant in the placed in the vitreous cavity which delivers 0.7 milligram of dexamethasone over a period of 6 months. It is injected into the vitreous cavity with a special injector through 22 gauge needle, and the concentration of this dexamethasone lasts for 6 months with the peak during the first 2 months. The complications of using corticosteroid in DME is that it can cause a rise in IOP and sometimes leading to refractory glaucoma and sometimes needing vitrectomy as well. The other complications of using steroids is nothing but it can cause cataract formation, and sometimes the patient complains of floater, something is floating in front of the eyes, and sometimes very rarely you can see the anterior migration. From the vitreous cavity, the implant can migrate into the anterior segment. The current indication of steroids in managing of DME is in refractory cases and in pseudophakic eyes without glaucoma or ocular hypertension, and also a patient with recent arterial thromboembolic event. I told you that within 3 months, if the patient comes with a DME, the anti-VEGFs are contraindicated. In those cases, steroids can be used as a agent and combined as a combined therapy with anti-VEGF agents. The advantage of steroids is not very less when compared to anti-VEGF, but it can be combined with anti-VEGF agents. The grid laser Grid laser is placing the laser spots 500 microns away from the macula, which are subthreshold in nature, and one spot in distance. The mechanism by which grid laser works is increasing the oxygenation of the inner retina, reducing the number of oxygen-consuming photoreceptors, and shortening the diffusion pathway to the inner retina. Focal photocoagulation is directed to in blasting the leaking microaneurysms, and it also improves the RP pumping of the sodium ions. The adverse effects of focal or grid laser is the most serious effect is inadvertent foveal burn, and other effects include central and paracentral scotoma, reduction in color vision, and causing development of CNVMs. To overcome this problem, subthreshold diode laser is being employed to reduce the complications of scarring and formation of development of scotomas. Subthreshold pulses are being used, but the disadvantage is there is no visible endpoint for treatment. The reduction in macular edema is slower, and more treatments are necessary to achieve this elimination. So, current indication for lasers is management of lasers in DME is management of non-center involving CSME, instances in which there is contraindication for intravenous injection, and sometimes as an adjunct to treatment, that is injections. Surgery in case of diabetic macular edema is very rarely done, and it's done in cases with vitreomacular traction, and refractory cases not responsive to any of the above therapy like anti-VEGF or steroid injections. Now, coming to the management of proliferative diabetic retinopathy, the gold standard, this pan-retinal photocoagulation is standard treatment in managing, which is again evident in landmark clinical trials like diabetic retinopathy and UKPDS study, which shows in this can you go back to the slide? You can see this in this animation that because of the effect of the photocoagulation, the new vessels and the blood which has leaked is shrinking. So, in high-risk proliferative diabetic retinopathy, the PRP is performed as soon as possible. In early PDR cases, PRP is performed once the maculopathy is stabilized under good metabolic control. In severe NPDR, in special clinical cases like if the patient has the poor compliance for follow-up, if the patient has other problems like renal issues and all, then in those cases we need to perform PRP even in severe NPDR cases. How does this PRP help? It is actually nothing but burning out the peripheral less used retina, so that the consumption of oxygen in the retina reduces. That reduces the VEGF production, and that's causing decrease in grading of the progression of the diabetic retinopathy. It also increases the oxygen in the inner retina and also production of vasoinhibitory factors. Now, advancements in laser is nothing but Pascal. It is pattern scanning laser. It is semi-automated laser delivery system which delivers laser pulses at shorter pulse duration in a rapidly predetermined spot pattern. It requires less total energy to produce burns, and also causes reduced pain and reduced scar expansion. You can see the difference in this image. The leftmost spots are single spot images, single spot laser being used, and the right part is the spots produced by Pascal. Now, one more advancement in laser is in Navilas, which is navigated laser delivery system, which has an eye tracking system, which minimizes inadvertent laser application to the fovea and other important structures, and it stops immediately with any eye movement. So it is fundus camera based, and without the usage of contact lens, so that's the reason patient will be more comfortable while performing this laser. So you can see here a defined area is marked for a laser, and it is performed automatically by the machine itself, and if there is any movement, it stops immediately. Coming to the surgical aspect of managing proliferative diabetic retinopathy, indications of vitrectomy in diabetes is nothing but non-resolving vitreous hemorrhage, or large premacular hemorrhage, or tractional retinal detachment involving macula, combined retinal detachment, vitreomacular traction, vitreopapillary traction, and non-resolving macular edema as discussed earlier. So the surgery for diabetic retinopathy is in which we make three standard pass panel ports. You can see first is vitreous being cut and blood is being removed. Blood is being removed in this, and then we cauterize the bleeders. This is performing cautery to stop bleeding from the bleeders. Removing the peripheral vitreous, that is what we call it as a base dissection. And lastly, we perform laser, that is endo laser. Then air, this vitreous cavity is filled with an air, followed by a, it might be replaced with a gas or oil. In this step, the saline is being replaced with air, and then it might be replaced with a gas or an oil. So with the advent of lower gauge vitrectomy ports, the self-sealing ports are helping in faster recovery of the patients. And lower gauge instruments, you can see here removing of the membranes, either in toto or using with the scissors. The pecs of fibrous membranes are being removed. In developed nations, advanced diabetic retinopathy changes are seen rarely. That is why, because of their improvement in their primary care for diabetes and effective screening programs they employ. So, coming to the examining schedule of diabetic patients, if the onset of diabetes is less than 30 years, the recommended time for first fundus evaluation is 5 years after onset, and routine minimum follow-up is annually. If the time of onset of diabetes is 30 years or more, then the recommendation time for first retinal evaluation is at the time of diagnosis, and routine minimum follow-up is annually. In females who are pregnant, the recommendation time for first examination is before or soon after conception, and routine minimum follow-up is at least every 3 months. So the problem is that not only the patient but also the patient care providers are not aware of the load and complications of diabetes retinopathy, and there is no national screening program for diabetic retinopathy in India. So there is a high need to screen patients effectively. This can be done by the screening the physicians, or by conducting screening camps, tele-screening and opportunity screening. So screening camps can be conducted in the community with the help of physicians, which also helps in increasing the awareness of the community regarding the diabetic retinopathy. Right. Okay. And there is another way of screening is telemedicine, where a technician is trained to take these fundus images in a center, and this images is sent to a satellite center where the ophthalmologist grades it and asks the patient to come if there is any requirement of any intervention. That also reduces the patient's travel cost and time, and also save the ophthalmologist's time in screening many patients in clinics. Then opportunity screening is nothing but screening of the patient at a diabetic clinic, where they employ a fundus camera and send the fundus images to a center, where the expert grades the center and send back his opinion. Now coming to the artificial intelligence, due to the inventions of the fundus scanning, newer fundus imaging modalities, this which can be easily assembled with Android or iPhones, and with the help of artificial intelligence developed software which can grade the diabetic retinopathy autonomously, there is an increasing scope of grading without the use of highly specified technicians, but still this is under research. To conclude, there is a need to improve the awareness of diabetic retinopathy in patients and also the healthcare providers, and improving the primary care for diabetes and proper referral system among the healthcare providers. At least high-risk individuals has to be screened early. With technological advancements, patients can have better access to proper screening and treatment and thereby prevent needless blindness. Thank you.
Treatment of it from the ophthalmologist's point of view. So it might have gone as a bomb sort of just for the audience. So my question to you is anti-VEGF and BRPC are complementary to each other, or you can do away with one of them?
No, the thing is, sir, I feel pan-retinal photocoagulation is the standard care. Anti-VEGF can add as an adjunct in some cases of if there is a severe diabetic retinopathy. We can add as an adjunct to reduce the severity of new vessels. So we can shrink those vessels and perform, and we can buy some time with for laser with anti-VEGF agents. But I don't think they go hand in hand, sir. Yeah.
In my request to the audience or the general physicians and the family physicians who refer the case, you are well versed with the financial condition of your patient. So try to prevent diabetic retinopathy. Once it occurs, send the patient if he cannot afford corporate or semi-corporate treatment, because setting up a retinal clinic by individual or group practitioner, it costs nearly 1 crore for diagnostics and treatment or OP treatment. So the doctor has to see at least 20 to 30 patients per month to pay the interest back, loan interest. So you cannot do free of cost. So you have to drill into the mind of the patient that you have to pay something to the doctor. He cannot do free of cost. If your patient cannot afford, send him to RIO, Regional Institute of Ophthalmology, Sarojini Hospital, which has got a good vitro-retinal team and a department where the care will be done free of cost. But for the सरकारी hospital के तक खाना पड़ता है, वो अपने patient, Muslim patients are not ready to do that. But they will, to start with, they will go to the say corporate or semi-corporate area. They will drain of their earnings or saving of that month for diagnostic only. When it comes to anti-VEGF, they have to shut down another 20,000 for the injection, and for OT cost, it was around an OCT pre and post injection. It costs around 25,000 package. So they will not have that treatment. So if they cannot afford, please send it to where it is done free of cost.
I would like to answer that at that case, one injection might not be enough, and the patient might need more injections. Again, it will causing further burden on his pocket. Yeah, we don't know how many injections the patient requires.
Special dietary method for prevention?
That has to be stated with the nutritionist or dietitian. But nothing, if blood sugars are under control, that will take care. Yeah. Yes.
Regarding screen, how are the non-dilating fundal cameras that are coming up?
Yeah, they are good to screen, but gold standard is dilated fundus examination, that I can say.
So if diabetic clinics that are set up, if there are non-dilating cameras, at least screens.
Yes, that is for sure. That's for sure. You can refer the patient. If you see a small lesion, also you can actually send the patient to a retina specialist where he can actually grade it effectively. But at least to detect those lesions, we can have this undilating fundus cameras on it.
Atherosclerosis and arteriosclerosis.
I didn't get you.
Arteriosclerosis.
That is usually seen in hypertensive retinopathy, but in the late stages of this also it can be seen. Any questions? Thank you. Dr. Musad, if you want to add something.
Yes, I want to tell one thing. The English promo prevention is better than cure. So that applies very well to diabetic retinopathy. With all to our general physicians, like controlling sugars is the utmost important thing that is present. Even after we develop diabetic retinopathy, many studies like DRCR.net and many other studies have shown that controlling sugars have prevented the progression of diabetic retinopathy to a great extent. So that is the utmost important thing, controlling of sugars in the patient. And timely giving treatment and counseling the patient, that is the most important.
So what a catchy point in this is patients who are on thiazolidinedione are more known for
DMA.
So I think whoever patients who are on triglycerides or
Those
I think they can be made alert and frequently screened for this.
Yes, that is. Yeah. Thank you so much.